This program is about home care for the patient who is recovering from hip surgery. After completing this program, you will be able to identify 2 precautions to promote safe ambulation, identify 2 important nutrients vital to recovery, describe 2 actions to prevent falls, and name 3 do's and don'ts for the patient.
That terrible sound. Someone has fallen down the stairs and fractured his hip. That one misstep leads to a complex sequence of events, a sophisticated surgical procedure, pain and anxiety, and a lot of special care and handling for a safe recovery. It's almost inevitable that you'll be called upon to play an important role in that recuperation for patients recovering from hip surgery. Each year, nearly 250,000 elderly people suffer from a hip fracture. The incidence of hip fractures among people over 50 doubles every 5 years. Women, especially those who suffer from brittle bones related to osteoporosis, are twice as likely as men to experience a hip fracture. Often the result is loss of independence, even death. To understand what happens, you should know a little bit more about the hip joint. The thigh bone, called the femur, has a rounded head. This rounded head, known as the femoral head, fits into a cup-shaped cavity, the acetabulum, in the pelvis. As the femur moves, the femoral head rotates in the hip socket. The arrangement is simple, and in the normal healthy adult, very strong. The ball and socket joint also allows the widest range of motion of any joint structure. A hip fracture or break in the femur generally follows trauma, such as a fall. The person will feel pain in the hip or feel something snap or give way. The affected leg usually looks shorter than the other leg, rotates away from the body, and feels unstable. The person has difficulty bearing weight or may be unable to put any weight at all on the leg. It takes a surgical procedure to repair the fracture. Surgery can include fixation of the hip with nails or screws, or replacement of the head of the femur bone, or even a total hip joint. The type of surgery depends on the location of the fracture. Did it occur in the head or the neck of the femur, or further down the bone? Other factors such as the patient's age, health status, bone structure, and level of mobility also affect the decision. Patients are usually discharged home walking with a walker or crutches. In your work, you may also care for a patient recovering from hip replacement surgery. Replacement of the hip joint is called hip arthroplasty or hip replacement. This has become one of the most commonly performed and successful orthopedic operations. People who undergo a hip replacement typically fall into one of 3 groups: those who suffer from osteoarthritis or rheumatoid arthritis, those who've experienced a certain type of hip fracture or failure of previous surgeries, or those with congenital hip disease. The purpose of the surgery is to improve or restore joint motion and function, reduce or relieve severe pain, and provide a greater stability to the hip joint. This reconstructive surgery usually replaces the 2 parts of the hip socket, the acetabulum and the femoral head. The orthopedic surgeon cements a polyethylene or plastic cup into place and then fits a stainless steel ball into the head of the femur. The surgeon determines the exact components and type of surgery depending on the patient's bone structure, joint stability, and other characteristics. Patients usually can walk with crutches within a few days. Near normal movement is restored in more than 90% of cases. As you can imagine, there's an amazing amount of detail to handle following a hip surgery. To help you, we'll use the Beacon parameters of care to organize the myriad of tasks and responsibilities. There are 8 parameters, each addressing essential points of care. Not every parameter applies to every patient, but the model can serve as a guide in learning how to care for your patients. What you've heard so far is part of the first parameter, the patient's condition or disease, including signs, symptoms, causative and contributing factors, methods of healing, and important points about the medical or surgical treatment. The second parameter, treatment, is one of the most important for the home care team. In this parameter, you learn about the patient's care at home, activity, exercise and mobility, skin care, elimination, special procedures, and the patient's psychological and social responses to the illness. Medications cover the drugs that the physician has prescribed for the patient. Your role in assisting your patient with medication depends on your agency's policies. Nutrition focuses on your patient's diet, food and fluid requirements, and snacks or supplements. You can assist in planning and preparing meals that will be right for your patient's situation. The monitoring parameter pays attention to the patient's signs and symptoms for early detection and treatment of problems. Monitoring can include temperature, pulse and respirations, blood pressure, urine or blood testing, lab tests, and ongoing medical care. Risk factors pinpoint the potential for injury, infection, or other safety and health risks so you can take appropriate action to minimize potential problems. In the parameter of complications, you'll find out about what signs and symptoms to report to the nurse and ways to prevent complications. And the last parameter identifies how you can modify the environment to assist the patient in achieving the best level of function and performance. Let's turn our attention back to the patient recuperating from hip surgery and how you can help. After hospitalization, the second parameter, treatment, becomes very important. For the patient who has had hip surgery, the goals of care are to facilitate the healing process, promote activity and mobility, and prevent complications. As you do whenever you care for a patient, you must fulfill some basic responsibilities when performing your duties. Check your assignment. Instructions should be precise so you know exactly what to do, when, why, and how. Develop a plan with the patient to accomplish your assignment. If the patient knows his or her role in care, cooperation can result. This also promotes the patient's participation in care planning and delivery. Because your patient is recovering from surgery, pay attention to infection control. Wash your hands before, during, and after care as necessary. Wear gloves when indicated. Properly handle soiled linens and disposables. Observe your patient's responses during care delivery. Report any significant observations and signs and symptoms to the nurse. Do not assist the patient with a task like ambulating on the stairs if you have not been assigned to do so. When in doubt about your patient's assignment or condition, contact your supervisor. There are some special considerations to remember for the hip surgery patient. Encourage the patient to participate in personal care and other activities. Follow a plan which balances activities and rest to avoid fatigue. Pay attention to the patient's skin. A patient who spends more time in bed is prone to skin breakdown. Keep the skin clean and dry. Inspect the skin, especially over bony prominences on the hip or tailbone. Report any redness or skin breakdown. Help the patient change positions in bed or when sitting in a chair, following the instructions in the assignment. Implement measures to minimize the possibility of any problems related to decreased mobility. The patient may wear anti-embolism stockings to prevent blood clots in the deep veins of the legs. You may be assigned to exercise the other extremities. Encourage the patient to breathe deeply and move arms and the non-operated leg. One of your most important responsibilities will be in assisting the patient with turning, transfers, or ambulation. Realize that the patient may be apprehensive, nervous, and afraid of injuring or dislocating the hip or experiencing pain or falling. Taking precautions for safe handling of the patient will promote healing and prevent complications. Know what activities the patient is allowed to perform and what limitations the patient may have. The patient should sit on a high, sturdy chair, avoiding low chairs or soft couches. Use pillows to elevate the seat or put blocks under couches or beds as necessary. The patient should slide the operated leg out to the front when sitting down and keep that leg out in front when sitting, not tucked underneath. To get up from the chair, the patient should slide towards the edge of the chair, keeping the operated leg in front, and then rise to a standing position, pushing off the arms of the chair or using a walker or crutches for support. Leaning forward, bending over, or reaching down is not recommended. The patient should not sit for periods of more than 30 minutes to 1 hour at a time. Encourage the patient to get up and move around. Be sure you understand your assignment before attempting to position or turn the patient in bed. The doctor will decide if the patient can or cannot turn onto the operated side. Know how to use any devices that will assist the patient in maintaining position. The patient should avoid adduction, that is, moving the operated leg toward the middle of the body. This type of motion can put stress on the recovering hip joint and could cause dislocation. Remind the patient not to cross legs when sitting, standing, or lying. Sometimes a pillow placed between the knees when sitting reminds the patient to maintain the correct position. The patient who has had a hip surgery will probably be on a home exercise program. The therapist will develop the program specifically for the patient, taking into consideration the patient's type of surgery, weight and motion restrictions, and other important factors. The therapist should instruct the patient in the program and develop specific instructions for you. Follow the instructions precisely as to the type of exercise, the number of repetitions, weight bearing, the amount and type of ambulation or use of equipment or assistive devices. Do not change the program without specific directions from the therapist. Document the patient's performance of exercises, noting how the patient tolerated the program and any other observations. It's very important that your patient follows the plan for ambulation established by the physician and therapist. That plan will describe a weight-bearing requirement for your patient. This is the amount of weight that the patient can place on the operated hip and leg when walking. Many patients are permitted weight-bearing as tolerated, which means according to their pain tolerance. If your patient has special weight-bearing instructions, you must know what this means, so talk with your therapist. That plan may also identify an assistive device for the patient to use when walking. There are 3 different devices: a walker, crutches, and a cane. The device and method of ambulation depends on the patient's age, level of mobility, any concerns about recuperation, the therapist's evaluation, and the physician's instructions. Since you'll assist your patient with ambulation, you must know the proper procedure. In the next few scenes, we'll demonstrate ambulation with a walker, crutches, and a cane. For the purposes of demonstration, we've placed a white X on the patient's operated hip. We refer to this as the patient's operated or injured leg. The non-operated leg is often referred to as the good leg, even though it's really no better than the other leg. It's just an easy way to communicate with your patient. Before assisting with ambulation, advise the patient to follow these instructions. Remove any obstacles to ambulation, such as rugs, furniture, or cords, and have the walking areas well lighted. Wear sturdy non-slip shoes, avoiding slippers, shoes with open toes, and so forth. Stand straight, using good posture. Walk with toes pointed forward, not inward or outward. Move slowly. We'll begin with the walker, a piece of equipment that many patients will use. A walker is an extremely light, movable apparatus about waist high, made of metal tubing, used as an aid in walking. It has 4 widely placed legs to provide support. To be of assistance, the walker must fit the patient properly. When the patient is standing within the walker with hands and arms outside, the hand grip should be level with the crease in the patient's wrist. If the walker does not fit properly, the therapist can adjust it up or down. The patient recovering from a hip replacement or fracture needs a walker to carry some of the body weight during walking, while the operated leg gains mobility and muscle strength. The patient should use the walker on flat surfaces. It's not recommended for going up and down stairs. To move forward, the patient should reach the walker out and place it down, resting hands on the hand grips of the walker. The patient moves the operated leg forward. Then, placing as much weight as permitted or tolerated on the operated leg and the rest on the hand grips, the patient steps forward with the good leg, passing the operated leg. The patient reaches the walker out, resting hands on the hand grips, and again moves the operated leg forward. Taking normal length steps with each foot, the patient continues to ambulate using this pattern. The patient should use the shoulders and arms to move the walker and not reach forward with the body or attempt to put all their body weight on the operated leg. Encourage the patient to look forward, not down, and to move slowly. This will result in better ambulation. The second assistive device for ambulation is crutches. Just as with a walker, crutches must fit the patient. If they don't, the patient can experience pain or difficulty in walking. To evaluate the fit of the crutches, rest the crutches on the floor 6 to 10 inches from the side of each foot. The top of the crutch pad should be 2 fingers width below the armpit crease. The top of the hand grip should be level with the crease at the patient's wrist as the arm rests straight down. If you have any concerns about the fit of your patient's crutches, contact the therapist. When ambulating with crutches, the patient should keep the crutch pads secure against the rib cage. This will keep the pads from sliding forward and back under their arms, creating irritation. Encourage the patient to put weight on the hands, not under the arms. Putting weight onto the crutch pads can result in a temporary or permanent loss of sensation in the arm, elbow, or wrist. To walk with crutches, the patient must follow a pattern of alternately bearing weight on one or both legs and on the crutches, called a crutch gait. The physician and the physical therapist evaluate the patient's ability to bear weight and then decide which crutch gait is best for the patient. In most cases, the patient is permitted to bear some of the weight on the injured leg, following a pattern of crutches, operated leg, good leg. If your patient uses a different gait and you are not sure how to assist, talk with the therapist. We'll watch as the therapist instructs the patient on crutch walking with partial weight on the operated leg. The patient should stand straight, with shoulders relaxed and arms slightly bent. The patient moves the crutches forward and then the operated leg up to meet them. Putting some weight on the operated leg, the patient moves the good leg ahead of the crutches. The patient should move the crutches only with the hands and shoulders while straightening the elbows and taking normal length steps. Crutches, operated leg, good leg. The patient continues to move forward in that sequence. Your patient may have to use crutches to go up and down stairs. Some patients do this because they live in a two-story home and it's the only way to get upstairs. Others may have crutch walking on stairs as a part of their exercise program to strengthen the hip and thigh muscles. Ambulating up the stairs may seem difficult, but encourage the patient to relax and be at ease. In ascending the stairs, stand behind the patient. You can prevent injury if the patient loses their balance. The patient should stand straight and walk up to the stairs with crutches. The patient moves the good leg up to the first step, bending forward at the ankle, then straightening at the hip and the knee of the good leg. The patient lifts the operated leg and the crutches up to that same step. The patient repeats this pattern from step to step. Remember, good leg first, then the operated leg and the crutches at the same time onto the same step as the good leg. Encourage the patient to look straight ahead, moving slowly from one step to the next until reaching the top. Ambulating down the stairs can be a frightening experience. The patient may fear falling headfirst down the steps. Some simple instructions can prevent a fall. Be sure that the patient's crutches are turned so that the wing nuts on the crutches are to the front. This will prevent them from hooking on the stair below. Stand in front of the patient. In case the patient loses balance, you can prevent a fall. Remind the patient to look straight ahead, not down. The patient gently places the crutches and the operated leg down to the first step, bringing the non-operated leg down to the same step. You can see the patient bending deeply with the non-operated leg as she moves the crutches and the operated leg to the step below. This bending motion helps keep the patient's weight over the foot on the step in back of her. In case of loss of balance, she would end up sitting on the step and not tumble down the stairs. The patient continues down the stairs, moving first the crutches and the operated leg together and then the non-operated leg. The patient should bear as much weight as possible on the good leg and the crutches. Remember, the patient's non-operated leg goes first when ascending and last when descending. Let's take a moment to review some of the important information you've learned so far. Can you describe the 8 parameters of care? Can you define your role in a home exercise program? Before ambulating, what instructions can you give the patient? What is the pattern the patient should follow when ambulating with a walker? What is the sequence of movement that the patient should follow to go up the stairs with crutches? What is the sequence of movement that the patient should follow to go down the stairs with crutches? As the patient becomes stronger and more stable, the physician may order ambulation with a cane. A cane is typically used to give support and mobility to an ambulatory but slightly disabled person. The cane will support any body weight the patient is not able to put on the operated leg. There are several types of canes. The one prescribed for the patient will depend on the patient's level of mobility and how often they go up and down stairs. The patient should follow the safety precautions we've already talked about and regularly check that the tip of the cane has no cracks or tears and is wearing evenly. To help the patient ambulate, the cane must be the correct length. The patient should hold the cane in the hand opposite the side of the operation. Our patient holds the cane in her left hand with a 30-degree angle at the elbow. The handle of the cane should be level with the crease in the wrist when the arm is down at her side. The therapist can adjust the length of the cane for the patient. When walking with a cane, the patient will move the cane and the operated leg together, and then the good leg. The patient can rest body weight on the cane and the operated leg while moving the non-operated leg forward. As with the walker and crutches, encourage the patient to take normal length steps, look straight ahead, and move slowly, keeping the cane fairly close to the body to prevent leaning. The therapist will instruct the patient in stair climbing as indicated. How the patient uses the cane on the stairs will depend on the level of the patient's mobility. Is the patient able to walk up and down stairs without using the handrail? Or does the patient feel uncertain and need that little bit of extra support the handrail provides? We'll show you how the patient should use the cane in both situations. First, the patient who uses the handrail. If there is a handrail on both sides of the stairs, the patient holds the cane in the hand opposite the operated leg, just as if walking on level ground. The patient grabs the handrail with the other hand. If there's only one handrail, as in our case, the patient should grab the rail with the closer hand and hold the cane in the hand opposite the rail, regardless of which hip was operated. To go upstairs, the patient steps up to the first step with the good leg and then lifts the cane and the operated leg together up to that step. The patient slides the hand along the handrail as necessary before taking a step. So the sequence is good leg up to the next step, then cane and operated leg together onto that same step. Remember that the purpose of the cane on the stairs is to support some of the body weight that the patient cannot bear on the operated leg. When descending stairs, the patient will again hold the cane in the hand opposite the railing and hold the handrail with the hand near it. The patient steps down with the cane and the operated leg and follows with the non-operated leg, bending both knees normally while stepping down. The patient slides the hand along the railing as necessary before taking a step down. So when the patient uses a cane on the stairs, the operated leg goes up last and comes down first. Once the patient has learned to go up and down the stairs using the handrail and has more confidence and stability, the therapist may permit the patient to use just the cane, not the handrail. In this case, the patient holds the cane in the hand opposite the operated leg, just as when walking on a level surface. The patient will step up first with the non-operated leg. Then, the patient lifts the cane and the operated leg to that same step. The patient continues this sequence up the stairs. To go down the stairs, the patient reverses the pattern. Holding the cane with the hand opposite the side of the surgery, the patient steps down with the cane and operated leg, followed by the good leg. Eventually, the patient may be able to go up and down the stairs with a normal pattern of alternating steps. This again is a decision that must be made by the therapist, and you should receive appropriate instructions. The patient will hold the cane in the hand opposite the operated leg. The patient steps up to the first step with the good leg, then lifts the cane and the operated leg to the second step. The sequence is good leg to one step, then the cane and the operated leg to the second step, and so on. When descending the stairs, the patient steps down to the first step with the operated leg and cane, followed by the non-operated leg to the second step. Cane and operated leg to one step, non-operated leg to the next step. Physical activity, exercise, and ambulation may cause pain for the patient recovering from hip surgery. The patient may be reluctant to move about if the pain is not controlled. That leads us to the next parameter, medications. The nurse will instruct the patient in various techniques to relieve pain, including positioning, exercises, and the use of medications, called analgesics. Your role may be to remind the patient to take the pain medication before any activity or procedure, like a therapy session, which could increase pain. Some analgesics can cause drowsiness, affecting your patient's ability to participate in activities. Watch for and deal with any safety issues. If the patient appears to be in more pain or does not experience relief after taking the pain medication, call the nurse. The patient recovering from a major surgical procedure needs extra attention to nutrition and fluids to promote healing, and the nutrition parameter will guide you. Check your assignment for any special dietary restrictions or limitations your patient may have. Assist your patient with meals if necessary. Give the patient time to complete the meal. If the patient does not have a good appetite, provide smaller, more frequent meals and serve the patient's favorite foods. When planning meals with your patient, use the food pyramid and food groups as a guide to healthy eating. To include some nutrients vital to the patient's health and recovery, incorporate the following foods whenever possible within your patient's diet and preferences. Foods high in calcium, such as milk and milk products, salmon, dark green vegetables, and dried beans and peas are essential for the repair of bones. Fortified milk and dairy products, salmon and tuna, contain vitamin D, which helps the body to absorb calcium. Protein foods like meat, poultry, fish, eggs, and milk help with the repair and maintenance of the body and wound healing. Vitamin C promotes healing and recovery and helps the patient resist infection. The patient should eat citrus fruits, tomatoes, strawberries, melons, and dark green vegetables. Water and fluids promote bowel and bladder function. Encourage up to 8 glasses of liquid a day as allowed. Because the patient's mobility is decreased, there may be a problem with constipation. Some nutritional tips can help prevent it. Encourage the patient to eat a well-balanced meal following regular meal patterns with plenty of fluids. Increase fiber by including nuts, bran, whole grain breads and cereals, and raw fruits and vegetables. If your patient is accustomed to a diet with little fiber in it, go slowly when adding fiber. Begin by increasing canned fruits, then cautiously add in salad greens, fruit juices, fresh fruits and vegetables, and bran. A problem closely related to constipation is intestinal gas. Patients with decreased mobility may experience a greater problem, which can not only be uncomfortable but embarrassing. If your patient suffers from intestinal gas, encourage activity within the limits of the plan. Try modifying the diet to exclude gas-forming foods such as peas, beans, wheat, oats, Brussels sprouts, cabbage, corn, rutabagas, and carbonated beverages. The next parameter, risk factors, addresses safety concerns. One of the biggest risks for the patient recovering from a hip surgery is falling. The normal changes of aging, such as decreased vision, particularly night vision, changes in posture or gait that can cause instability, slowed reaction time, and decreased strength and coordination contribute to the chance for falls. If your patient suffers from a chronic disease, add in muscle stiffness, rigidity, dizziness, or loss of consciousness. After surgery, the patient may be weak, anxious, unsteady, or fearful. Inexperience with using an assistive device can also contribute to accidents. You can begin to see why preventing falls becomes a primary goal of care. Teach the patient to be alert to hazards and behaviors that contribute to falls. Falling usually results from an accident on cluttered stairs or walking into furniture that obstructs the pathway. It can also result from inattentiveness, moving too fast, or being careless. Work with your patient to identify and remove hazards, such as throw rugs, clutter on stairs, loose carpeting, and furniture that has sharp edges or glass tops. Rearrange the furniture to ensure a clear path. Provide adequate lighting. A nightlight can improve vision at night. Light switches at both ends of a hallway or the top and the bottom of stairways promote safe travel. Check the patient's equipment frequently for any loose screws and clamps, malfunctioning parts, or limitations in movement. You can see that by identifying risk factors, we've crossed right over into the next parameter, environment. The nurse and the therapist will work with the patient to modify the home environment to prevent falls and accidents. Your role will be to assist the patient and the family in carrying out these modifications to keep the environment safe. The patient may also use some other assistive devices to improve their ability to function. A raised or elevated toilet seat makes it easier for the patient to use the bathroom independently. Grab bars in the tub and shower promote safety. A shower bench can promote safe bathing. The grab bars and shower bench should be high enough to prevent the patient from bending. Talk with the therapist about any concerns you may have. Your assignment will note your role in monitoring the patient's status for important signs of complications and problems. Watch carefully for signs and symptoms of infection, such as chills, fever, redness, swelling, tenderness or unusual drainage, increased pain, skin breakdown, bleeding, loss of sensation, pain in the foot on movement, or redness or pain in the calf on dorsiflexion, that is, flexing of the foot upward. Report these signs and symptoms to the nurse immediately. When in doubt, call the nurse. And the final parameter in our discussion, complications. The main complication that the patient may experience is dislocation of the hip. Dislocation occurs when the head of the femur slips out of the hip joint, causing pain, rigidity, shortening of the leg, and loss of function. If this occurs, the patient will require emergency medical attention. You can help prevent a hip dislocation by following the positioning and ambulation techniques we covered in this program. Here are some important do's and don'ts for the patient. When standing, keep your legs shoulder width apart. Use good posture and look straight ahead when walking. Move slowly following the procedure for ambulation. Slide the operated leg out in front as you sit. Get up from the chair slowly. Sit only with your knees lower than your hips. Use assistive devices to help you. Don't cross your legs when you sit or stand. Don't sit in a low chair or elevate your feet on a stool. Don't bend the operated leg underneath when sitting in a chair. Don't sit for more than 1 hour at a time. Don't use devices for ambulation until you've been instructed. And don't bend down to pick up objects. How about some more questions to test your knowledge? In which hand should the patient hold the cane when walking on level surfaces? In which hand should the patient hold the cane when using a handrail to go up the stairs? Which nutrients are essential to your patient's recovery? What's the biggest risk factor for the patient recovering from hip surgery? What can you do to help lower the risk? Can you name 4 do's and don'ts for the patient to follow to prevent dislocation of the hip? We've covered quite a bit of information in this program. Important information because you'll play a vital role in caring for the patient who has had hip surgery. You may be the first one with the opportunity to spot potential dangers, see signs and symptoms, set an example for others, alleviate fears, and promote the patient's best level of health and performance. The excellence of care you deliver will depend on your awareness, planning, sensitivity to the patient's needs and situation, and constant vigilance. The parameters of care can guide you in providing safe and comprehensive care to help the patient who has had hip surgery recover at home.